The human brain, it's our most complex organ capable of truly amazing things. But, it's also incredibly fragile. A single moment of fall, a car crash, some kind of impact, and everything can change. We're talking about traumatic brain injury or TBI. It's a term people hear, but do we really grasp its impact? It can be staggering and often hidden. So today on the deep dive, our mission is to really unpack this complex world for you. We want to go beyond just the headlines. We'll explore what TBI actually is, the forces involved, how it's diagnosed, managed, and what that recovery path looks like. Think of this as your shortcut to getting informed without wading through dense medical texts. We've pulled insights from clinical lectures, task analyses, outcome measures, all the good stuff, really, to bring you the key knowledge.
Right, and to get started, the basic definition is crucial. TBI is essentially any evidence of brain pathology, damage, basically, that comes from an external force. And that force can be, well, diverse. It could be something severe like a gunshot wound or a major motor vehicle accident, but it could also be a simple fall. That's actually a really common cause, especially for older adults.
So it's that initial hit, that external force causing the primary injury, the direct damage.
Exactly. That's the primary injury, the direct trauma right at the impact site, a contusion, a laceration.
But there's that really counterintuitive idea that coup contra coup injury. How does the brain injure itself twice like that? It sounds almost paradoxical.
It does, but it makes sense when you think about the physics. Imagine a sudden jolt, like in a car accident. The brain first slams against the front of the skull, that's the coup. Then, as the head snaps back or stops suddenly, the brain rebounds and hits the back of the skull. That's the contra coup.
Wow, so damage on opposite sides from one impact.
Precisely. And those same kinds of forces, the shearing and compression, can also cause something called diffuse axonal injury, or DAI. This isn't focused in one spot. It's microscopic tearing of the nerve fibers, the axons, all across the brain, often linked to moderate or severe TBI.
Microscopic tearing. That sounds hard to spot.
It can be. And that's the tricky part. DII might not even show up clearly on an initial CT scan because the damage is so, well, diffuse and small scale initially. It disrupts the brain's wiring.
That's quite insidious. And then there are blast injuries, which are different again, right? More common in military situations.
Yes, exactly. With blast injuries, it's not usually a direct hit. It's the shock wave from an explosion. That wave creates this overpressure effect that travels through the body and can cause brain swelling, cerebral edema, and other damage without direct impact to the head itself.
So we have the primary hit, the direct damage, but the brain's reaction doesn't just stop there, does it? There's more that happens afterwards.
No, absolutely not. That's where secondary injuries come in. After the initial trauma, the body kicks off an inflammatory response. It's trying to heal, but this cascade histamine release, other chemicals rushing in, can actually cause more harm. It leads to that cerebral edema, the swelling. And that swelling increases pressure inside the skull intracranial pressure, or ICP. Plus, you can get problems like hypoxemia, not enough oxygen or hypotension, low blood pressure, which makes everything worse.
Right, and that increased pressure, that sounds incredibly dangerous, especially since the skull is a closed box, essentially.
That's exactly the danger. You've got brain tissue, cerebrospinal fluid, and blood all packed inside the skull. If any of those increase in volume, usually the brain's swelling from edema, the pressure of the ICP goes up. Normal is roughly 5 to 20 millimole Hg. Anything higher than that is a serious problem. It can reduce blood flow to the brain, starving it of oxygen. Or worse, it can cause herniations.
Herniations, where the brain actually shifts or squeezes.
Yes, parts of the brain get pushed into spaces where they don't belong through openings within the skull structure. It's a neurological emergency, indicating severe pressure, needs immediate action.
Okay, so we understand the mechanics a bit better now, but how does all this damage actually show up in a person's life? The clinical side must be incredibly varied.
Hugely varied. And that's where something like the ICF model, the International Classification of Functioning, Disability, and Health, is really useful. It helps us look at the whole picture. So the health condition is the TBI itself. Then we look at body structures and functions, the direct impairments. For example, damage to the right side of the brain might cause spatial neglect, where someone ignores the left side of their world.
So they might bump into things on their left.
Exactly. Or even get indirect problems, like maybe wounds on their left side because they aren't aware of them. And that neglect could lead to social isolation, maybe depression.
Ah, so that ties into the other ICF levels.
Right. The activity limitations, like the difficulty walking around obstacles because of the neglect. And then participation restrictions, maybe they can't go out to eat anymore or join community groups. And the model also includes contextual factors, environmental things like how much social support they have, and Personal factors like their own motivation both really impact recovery.
Beyond that framework, TBI often brings cognitive issues, similar perhaps to other brain injuries, but with some specific patterns.
Yes, you often see challenges with arousal, attention, concentration, learning new things, memory, and especially executive functions.
The planning, organizing part of the brain.
Exactly. Things like initiating tasks, planning, problem solving, inhibiting impulses, sequencing actions. These higher level controls can be significantly affected.
And in more severe cases, there are disorders of consciousness. It's not just about being awake or asleep, is it?
No, it's a whole spectrum. You have coma, where someone is completely unresponsive and can't be woken up. Sometimes that's medically induced, actually, to let the brain rest. Then there's the vegetative state. Here, the person might have sleep-wake cycles. Their eyes might open, but there's no conscious awareness. They might react to pain, which can be very hard for families.
Because it looks like awareness, but isn't.
Right. Then you move to the minimally conscious state, where there are small, inconsistent signs of awareness, maybe reaching for an object or tracking something with their eyes, but it's not consistent. And we also talk about stupor, needing strong stimulation to be aroused and obtunded, where they're drowsy, slow to respond, and drift back to sleep easily.
It sounds like a very slow, gradual, and probably difficult progression to track. And then there are the visual and perceptual issues too. But TBI often involves the frontal lobes, doesn't it? Because of how accidents happen. That brings us to cases like Phineas Gage. That story is unforgettable.
It really is. Phineas Gage, the railroad foreman in 1848, an iron rod went straight through his left frontal lobe. He survived, miraculously for the time, but his personality completely changed. He went from responsible and well-liked to impulsive, irritable, and unreliable.
It was one of the first times we really saw proof that specific brain areas control personality and decision-making, right? A real aha moment.
A landmark case, absolutely. And it highlights those executive function and personality changes we often see after TBI. Beyond that, there are other neurological complications. Seizures are quite common, maybe up to 50% in severe TBI, usually managed with medication. There's also dysautonomia problems with the autonomic nervous system. You might see things like a racing heart, high blood pressure, fast breathing, lots of sweating. The body's fight-or-flight system stuck on high alert.
That sounds exhausting and dangerous. And you mentioned specific posturing earlier as a critical sign.
Yes, specific postures can indicate very severe injury, particularly to the brainstem. They're emergency signs.
Like decorticate posturing. Can you describe that?
Decorticate involves abnormal flexion of the arms, elbows, wrists, fingers bent inwards towards the core of the body, while the legs are extended and rotated inwards. It points to damage higher up in the brain, above the midbrain.
And decerebrate.
Decerebrate is generally considered more severe. Here, the arms are also extended, straight and rigid, often rotated inwards, along with the extended legs. It suggests injury lower down, potentially involving the brainstem.
And these postures tell you something about prognosis too, don't they?
Sadly, yes.
Yeah.
They are critical indicators. Survival rates are significantly lower, especially with decerebrate posturing, around 37% for decorticate, but maybe only 10% for decerebrate. Recognizing them is vital.
Given all this complexity, the injury types, the cognitive effects, the medical emergencies, it's obvious one person can't handle this alone. An interdisciplinary team is key, I assume.
Absolutely essential. You need physical therapists, occupational therapists, speech therapists, doctors, neuropsychologists, social workers, case managers. It's a whole team effort. And crucially, the patient and their family have to be at the center of that team. Their input, their goals, their support network, it's all vital.
Okay, so in those first critical hours and days, what's the immediate focus for that team?
Job one is stabilization. Keep the blood pressure up, make sure oxygen levels are good, systolic over 90, O2 saturation over 90%. Then it's about preventing those secondary complications we talked about, identifying every single injury the person might have sustained, and just constant close monitoring.
And how do they actually diagnose the TBI and figure out how severe it is?
Several tools are used right away. The Glasgow Coma Scale, the GCS, is fundamental. It scores eye-opening, verbal response, and motor response. A score of 8 or less is severe, 9-12 is moderate, 13-15 is mild. Gives a quick baseline severity. Then, maybe a bit later, the Galveston Orientation and Amnesia Test, or GO8, checks orientation person, place, time, and memory loss or amnesia. It helps track cognitive recovery. Combining these scores with observations of their level of consciousness, any altered consciousness, how long post-traumatic amnesia lasts, and importantly, neuroimaging that gives the full picture.
Neuroimaging like CT scans.
Yes, CT is usually the first choice. It's fast and really good for seeing immediate problems like bleeding, hematomas, brain shifts, changes in the fluid-filled ventricles, things that need urgent attention.
So if that CT scan shows swelling and confirms that intracranial pressure is dangerously high, what can be done?
There are quite a few strategies depending on the cause and severity. If a blood clot or mass is causing the pressure, surgery to remove it might be needed. Medications like diuretics can help pull fluid out. Simply positioning the patient with their head elevated to about 30 degrees can help drainage. Sometimes sedation and ventilation are used to reduce the brain's metabolic demands.
Yeah.
CSF, the cerebrospinal fluid, can be drained off through a lumbar puncture or a ventricular drain.
More invasive techniques, too.
Yes, things like controlled hyperventilation to constrict blood vessels temporarily, therapeutic hypothermia to cool the body and slow metabolism, or even putting the patient in a medically induced coma. And in extreme cases, decompression surgery, a hemicraniectomy or craniotomy, that involves removing a piece of the skull.
To give the brain room to swell without being crushed. Wow.
Exactly. It's a life-saving measure in some situations.
And I imagine after that kind of surgery, you'd need serious precautions, like wearing a helmet during rehab.
Oh, absolutely. Protecting the brain when the skull flap is off is critical during any mobilization or therapy. Safety first, always.
Okay, let's pivot to the longer-term recovery. Predicting how someone will recover from TBI must be incredibly difficult.
It really is. There's no crystal ball. Prognosis depends on so many factors. The initial injury severity is a big one. The GCS score matters. Age is also important. Younger brains tend to have more plasticity, more ability to reorganize. The time since the injury counts. Most rapid recovery is often in the first 6 months, but improvement can definitely continue for years.
And personal factors.
Hugely important. Motivation, family support, social resources, these make a massive difference. Also, clinical signs like whether the pupils react to light, what the CT scan shows initially about lesions or pressure, it all feeds into the prediction.
So with all those variables, how do clinicians actually try to estimate outcomes or guide treatment? Are there specific tools?
There are. The Glasgow Outcome Scale, or GOS, is a common one. It gives a broad category: good recovery, moderate disability, severe disability, vegetative state, or death. Useful for big picture planning.
But maybe not sensitive to smaller changes.
Exactly. It might miss subtle improvements. For more detailed prediction, especially early on, there's the CRASH calculator. It's a web-based tool from the Medical Research Council. You plug in data age, GCS, pupil reaction, other injuries, CT findings, and it estimates the risk of mortality at 14 days and unfavorable outcome at 6 months.
That sounds powerful for having those really tough conversations with families, giving them some data-driven context.
It is. It helps frame expectations and guide incredibly difficult decisions, grounding them in evidence as much as possible.
Now, thinking about the rehabilitation itself, especially physical therapy, I know task analysis is a really core concept.
Yes, task analysis is fundamental. It's how therapists break down any movement or activity into its smallest parts to see exactly where the difficulty lies.
Using that framework by Hedman and colleagues, initial conditions, preparation, initiation, all those stages.
That's the one. Initial conditions, preparation, initiation, execution, termination, and outcome. Let's take a simple sit-to-stand transfer for someone with TBI, say a 65-year-old man. The therapist watches closely. Maybe they see he hesitates before starting, initiation delay. He relies heavily on his right arm to push up execution. There are slight tremors, maybe some unsteadiness or ataxia in his movements, execution. He sways a bit when he finally stands up, termination outcome.
So those observations lead to ideas about the underlying problems.
Precisely. The therapist forms hypotheses. Maybe decreased static balance, resting tremor, poor spatial awareness affecting his movement, maybe muscle weakness or loss of motor control, ataxia. And then he uses specific tests, motor control tests, strength tests, balance scales like the BOG, functional tests like the 30-second sit-to-stand to confirm or refute those hypotheses and target the therapy effectively.
And making sure that therapy and the way we measure progress is actually effective. That involves using evidence-based outcome measures, right? Like the TBI EDG recommendations.
Yes. The TBI ADG task force did a huge service by reviewing dozens and dozens, I think 88 outcome measures used in TBI rehab. They looked at the psychometrics. Is the test reliable? Is it valid? Does it measure what it claims to measure? And also clinical utility. Is it practical to use? How long does it take? Does it need special training?
And they categorized them.
They did, into 4 levels. Highly recommended, great science and practical.
Yeah.
Recommended, good science, practical, reasonable to use, good science, but maybe less TBI-specific research. And do not recommend, poor utility or psychometrics.
Can you give some examples of highly recommended ones?
Sure. For inpatient settings, especially with disorders of consciousness, the Coma Recovery Scale Revised, CRSR, is highly recommended. It's really good at distinguishing between vegetative and minimally conscious states. Takes maybe 15, 30 minutes. Also inpatient, the MOS Attention Rating Scale, RRS, is great for tracking attention-related behaviors, and it's quick, just 5 minutes.
And for outpatients, maybe higher level patients.
For higher-level mobility in outpatients, the High-Level Mobility Assessment, HINAT, is highly recommended. It looks at things like running, jumping, stairs
Yeah.
for people walking independently. Takes 5, 10 minutes.
And there are others just recommended.
Oh, yes. Lots of good ones like the Disorders of Consciousness Scale, DOCS, Agitated Behavioral Scale, ABS, the Community Integration Questionnaire, CIQ, the 6-Minute Walk Test, the Berg Balance Scale. The point is to use standardized, validated tools to track progress objectively.
It makes sense. Using the right tool for the right patient at the right time. And underlying all of this recovery, all this therapy, is neuroplasticity, isn't it? The brain's ability to change.
That's the magic, really. Neuroplasticity is the biological basis for recovery. The brain isn't static. It can reorganize itself after injury. And we use principles of neuroplasticity to guide rehab.
Like, use it or lose it.
Exactly, and use it to improve it. Neural pathways weaken without use, but practice strengthens them. Specificity is key. You get better at what you practice. Intensity and repetition matter. You need enough practice at a challenging enough level to drive change. Salience is important too. Tasks that are meaningful to the patient are learned more effectively.
So, like incorporating gardening if they love gardening.
Precisely.
Yeah.
Timing also plays a role often. Earlier rehab yields better results, though recovery can happen years later. Age influences plasticity. Yes, younger brains might adapt more readily, but older brains absolutely still change. And one tricky one is interference. Sometimes learning a compensatory strategy early on, while helpful then, might actually make it harder to relearn a more normal movement pattern later.
That raises a really interesting question. How do therapists balance helping someone function now with strategies versus pushing for the potentially harder, longer path of restoring more normal function for the long term?
That's a constant clinical challenge. It requires careful judgment, ongoing assessment, and collaborating closely with the patient and family about their goals. There's no single easy answer there.
Wow. What an incredibly thorough journey through a traumatic brain injury. We started with the mechanics, the forces, the primary and secondary damage. Then we moved through the huge variety of clinical presentations, from subtle cognitive changes right through to disorders of consciousness and those stark posturing signs. We covered the vital interdisciplinary approach, the diagnostic tools like GCS and CT scans, and the critical interventions for managing things like intracranial pressure. And finally, we really dug into recovery, the complex factors influencing prognosis, the importance of task analysis and evidence-based measures in rehab, and the amazing fundamental role of neuroplasticity.
So what does this all boil down to for you, the listener? I think it means understanding TBI goes way beyond just the brain tissue itself. It touches on the very essence of personal identity, the profound link between our brain's health and who we are. It's a stark reminder of vulnerability, yes, but also a testament to the brain's incredible capacity for adaptation, for change, even after significant injury. And maybe most importantly, it highlights the immense human spirit involved in navigating these profound, often lifelong changes, both for the individual and for everyone who supports them on that journey. It's never truly over.